All right. Well, thank you everybody for signing in for the Pain and Palliative Care webinar series for this week. Once again, poor Dr. Ray has been saddled with doing the presentation, but I'm sure if it's anything like last week's, it'll be phenomenal. Today's topic is methadone use and palliative care. And with that, I will turn it over to Dr. Ray. Thanks again for agreeing to do this, and we'll all be anxiously awaiting your teachings.
Thank you, Chris. Thank you again for anyone that has came from last week, and thank you for anyone new that has came to watch me present. So like Dr. Herndon said, I'm going to be talking about methadone and its use in palliative care. So looking at a little bit of the history of methadone, it's been around for a really long time. It was first approved by the FDA in 1947, and it was discovered to be daily maintenance doses of methadone, which allowed individuals to it was approved in 1947, I should say. 1950s, it started getting used for withdrawal symptoms of illicit drugs like heroin to kind of help treat those symptoms. Coming to 1960s, that's when it was starting to kind of be used as a maintenance therapy to help people who are addicted to opioids, illicit and non-illicit, to kind of maintain normal life, to prevent withdrawal symptoms, to kind of go on with life without having these cravings of opioid therapy when they are taking methadone for treatment of opioid withdrawal. So just some statistics I'll talk about. In 2009, there was about 30% of the deaths that were related to opioids were related to methadone use. So it's a very dangerous drug, which I'll get into a little bit, but it's also very beneficial. So as far as the overdose deaths on methadone, it actually has been decreasing outside of the age group of 55 to 64 since 2006. And overall opioid-related deaths have been increasing. So overdose deaths outside of that age range have been decreasing in methadone use. However, overall opioids have been increasing. So the FDA came out with some recommendations to kind of help guide some of this back when it became a big problem. One thing, the dosing interval used to be every 3 to 4 hours for methadone, and they changed that to typically every 8 to 12 hours. Now, sometimes you can do Q6, but typically the normal scheduling for methadone is every 8 to 12 hours. They also agreed, the DEA kind of talked to the methadone manufacturers and determined that the largest formulation of methadone that they were going to produce was 40 milligrams. Prior to that, there were higher doses, but they have since stopped making those different dosages. And then there's been at least 18 or 16 states that have removed methadone from their Medicaid preferred drug list to kind of reduce some patients for using methadone for routine pain. So overall, what I'm going to kind of go over with methadone is it's used for opioid addiction and chronic pain. I'm going to be focusing on the chronic pain part of it since that's more in palliative care. Some problems with it is it has a long and variable half-life ranging from 16 hours to over 100 hours. There are quite a few drug interactions that we as pharmacists need to be aware of, which I'll go over. And then there's variability in the equianalgesic dose ratio depending on how high of an opioid dosage they are on prior to starting methadone, which I'll get into a little bit. And there are all kinds of conversion tables. There's not one consensus about the best conversion table, which I'll kind of ask your guys' input about what you guys use when we get to that point. And then one of the problems associated with death is QTC prolongation, which I'll talk about a little bit more as well later on. So methadone, how does it work? Essentially what it is a mu opioid receptor agonist. It is also a delta and kappa agonist as well. However, kappa is not as significant as the delta and mu opioid receptors. So outside of the opioid receptors, it also works on serotonin reuptake. It inhibits that. It inhibits norepinephrine reuptake, which can have beneficial effects in neuropathic pain. And it also works on the NMDA receptors, which has been found to work in prevention of central sensitization and also to reduce opioid tolerance. A third thing that NMDA receptor antagonism has been found is to help treat neuropathic pain. So it really has two routes to help treat neuropathic pain outside of the opioid effect to treat overall generalized pain. When thinking about methadone, it's important to realize that it is a racemic mixture, and it is different than like warfarin, where S is the more potent, or super warfarin. This one, the R form, is more potent. You can see 8 to 50 times more potent, and it's actually responsible for the mu opioid receptor activity. The S doesn't have a whole lot to do with the mu opioid receptor form, but both the R and the S racemic mixtures do have NMDA activity. As far as the QTC prolongation, it has been more associated with the S racemic mixture. Some general pharmacy kind of things we'll talk about with methadone is ADME, so absorption. It is a very lipophilic drug. It is largely retained in the liver and secondary tissues, and it is slowly released back into the plasma during redistribution and elimination. It also does have a high bioavailability in the oral formulation. It depends on if you're taking a pill or liquid, but they are very similar, typically about 75%. So I've seen anywhere from 75 to 95% bioavailability in these products. As far as the distribution, as I said, it was distributed throughout the body to a high extent, but it is also protein bound. It binds to alpha-1 acid glycoproteins, albumin, and globulin. And the binding varies from patient to patient, which could contribute to some of the variability in response that we see with methadone in patients. There's also, as far as the metabolism, it goes through N-demethylation to inactive metabolites. It is converted to 2-ethyl-1,5-dimethyl-3,3-diphenylpyrrolidine, or EDDP, which is eliminated through the urine in feces. And then the metabolism happens in the liver to the most extent, as most medications are, and then to a small extent in the gut. As far as excretion, it is mostly excreted in the fecal matter, so it also is inactive metabolites when it is excreted. There is minimal amount of urinary excretion. However, if the urine does become more acidic, it does increase the urine clearance. And as far as the elimination half-life, it ranges from anywhere from 5 to 130 hours, which is a huge difference, especially when trying to determine the steady state for these patients. Another problem with that is we can't really determine that number in different patients. It's more going to be based on response to the medication and adjusting at that point. So who is a candidate for methadone therapy? Well, I guess the first thing to really realize is, are they a candidate for opioid therapy or narcotic therapy to actually treat whatever pain they may have? So that is going to be the first step in determining who is the most appropriate for this medication. But then you're going to have to look at, okay, are you going to go with traditional opioids? You're going to go with methadone. So some reasons why you might choose methadone over other opioids would be is if they have a true morphine allergy, so anaphylaxis, not just hives or what could be associated with a histamine response. We're talking about a true morphine allergy with anaphylaxis. They may be a candidate. If they have renal impairment, really there's only two opioids that have good data in renal impairment, and that's fentanyl and methadone. The other ones are kind of wishy-washy depending on if they have toxic metabolites like morphine or if they're just more of a precautionary thing. As far as neuropathic pain, as I said, there's kind of two mechanisms where methadone kind of helps treat neuropathic pain, the NMDA receptors and having norepinephrine antagonist activity. So it has kind of two benefits in neuropathic pain if they are having neuropathic pain with co-occurring other kind of pain. Big benefit of this medication is cost. Since it's been around for so long, it's a very cheap drug. Now realize that sometimes pharmacies have problems getting the drug, but it is a very cheap medication and very affordable for patients. One unique thing about methadone is the only long-acting opioid liquid that we have on the market. The duration of action is typically 4 to 8 hours for this medication, but that does have a unique niche, and especially in palliative care, being a long-acting liquid. And then later on, I'm going to talk about its use as a coanalgesic on top of other opioids that patients may be having, especially in patients that are on high-dose opioids, supplementing those with methadone to help get these patients under control. Some other potential candidates may be if they're having opioid adverse reactions, such as psychosis or some kind of severe reactions to other opioids, or patients who require long-acting opioids, especially if they want the liquid formulation. So initiation, I'm not really going to go over the opioid addiction, but for that, it's usually 30 to 40 milligrams once daily. When you're first initiating this therapy, there's kind of two trains of thought. You got to figure out if they're on low dose opioids or high dose opioids. And there's all different kinds of calculations, which I'll get over, to determine what the appropriate dose is, or at least different conversion tables to kind of help guide. So if they are on low dose opioids, which is considered 40 to 60 milligrams of oral morphine equivalents, at least the guidelines from 2014 recommend 2.5 milligrams 3 times daily as a starting dose. Now, this is not set in stone. Obviously, this is a guideline, so this is there to guide us. Some patients, I said, this wouldn't be appropriate, and it might be more appropriate to go 2.5 twice daily, or even 1 milligram twice daily, depending on really the risk factors and what you're going to be worried about with some of the side effects I'll talk about. If they're on high dose opioids, however, what you're going to do is calculate the oral morphine equivalents. And according to the 2014 guidelines by the American Society of, by the American Pain Society, you would calculate that oral morphine equivalents and reduce the dose by 75 to 90% with a max dose of 30 to 40 milligrams per day. Now, this is a huge reduction in dose, but there are other guidelines or are other guidance out there that say different variations in that actual reduction. But that is something to keep in mind, that the latest guidelines do say to reduce that dose by 75 to 90%. As far as converting to methadone, it's unlike other opioids, as I mentioned a little bit earlier, there's no linear relationship. So when you think about other dosage strategies, if you're going from morphine to, let's say, hydrocodone, something simple, it's a 1-to-1 ratio. So if you're on 100 milligrams of morphine, you would assume 100 milligrams of hydrocodone. If you're on 100 milligrams or 1,000 milligrams of morphine, you would assume 1,000 milligrams of hydrocodone would be equal analgesic. With more methadone, that isn't the case. The higher dose of opioids you are on, the higher that conversion factor is. And that's due to there's different proposed mechanisms as to why they think that happens. We don't have one, but essentially there's some things to really think about. And one of them is altered binding to opioid receptors. So essentially the molecular structure of methadone may alter the binding to opioid receptors, resulting in less cross tolerance to methadone. And that could be due to the NMDA activity, since that does kind of reduce tolerance, or it could be due to other factors of methadone, which kind of have more potent of an effect. We know cross tolerance between opioids is one thing, but methadone is a special case where you really have to look at their total opioid dosage daily to help you convert. Another thing is, some people say pro-analgesic effects of other opioids, such as like oxycodone, where some of the byproducts could have actual a pro-analgesic effect instead of being an analgesic, where it reduces pain. It could increase pain, but a lot of these are just speculation. We don't have really good data to say why this conversion happens. We just know that these are some of the potential reasons as to why we have to determine the conversions like this. Another thing to realize is this is talking about converting to methadone. When you're talking about converting from methadone, you can't use these conversion tables because it would be inappropriate. Really, the dose, from what I've understood and what I've read, the ratio is about 4.7 to 1 when you're converting from methadone to another opioid. You'll see in a couple slides that these conversion tables, that is completely different than what we would do converting to methadone. So here's one of the first conversion tables that came out by Aug19, which essentially breaks down the different oral dosage morphine equivalents and then gives you an oral morphine to oral methadone ratio. So you can see here that it goes up to greater than 1,000 milligrams, and that would be 21 ratio, and then down to less than 100 milligrams, which would be a 3-to-1 ratio, and everything in between. Gazelle came out with a Fast Facts publication in 2009, essentially took Aug19's or I'm not sure if I say that right, but took their conversion table and made it 25% decreased due to incomplete cross tolerance that we know is there. So this is the same one as the one previously. However, it is a little bit more strict in making the doses decrease due to incomplete cross tolerance. However, he only decreased it by 25% from the original table. There's another resource that we could use, which is the methadone package insert, which essentially looks at the methadone and does a percentage of the daily morphine, which would take into account some of the incomplete cross tolerance that we see with methadone. And then there's another one that came out in 2001 by Mercadante, which essentially only goes up to 300 milligrams, but it's a very simplistic way to look at it. And the beneficial thing about this one, it actually does have different ratios between 30 to 90. So the other one started at 100. This one actually goes to 90, which could be beneficial if patients are on low dose opioids. So now I'm going to kind of open up and figure out, what conversion chart do you use in your clinic or in your site, or which ones have you had the most experience in using? Ooh. Sorry guys, my tables were not going over. I'm using two different screens here and I didn't realize that this wasn't. So essentially I'll go back over this again. Here's the tables that I was talking about as far as the different dosing formulations. This was the one that came out first, and this one was when Gazelle came out with Fast Facts and decreased that dose by 25% to make these dosages more strict, and the methadone would be less. This is the methadone package insert, which looks at between 100 milligrams and 1,000 milligrams. And then this is Mercadante, where he goes from 30 milligrams to 90 milligrams with different ratios, between 4-to-1 ratio all the way up to a 12-to-1 ratio when the dosages are greater than 300. The problem with this one is that really, if the dosages are a lot higher than 300, you really could be overdosing these patients, and some of the ratios do go up to 20. And now my conversion chart. So which one do you guys use? Check. Okay, Chris uses the Mercadante. Sorry about the slides. CDC. And really, I don't know if there's a best answer to this. I think it's going to be what's most comfortable with, and I think sometimes so there's a lot of variation from what I'm seeing in dosage changes. Is that a 10-to-1 ratio for all patients, or is that change with the dosages? Well, thank you guys for participating and letting me know what you guys use. It's very interesting. And as you can see, there's a lot of different options of charts. And like I said, these aren't the only ones listed. But yeah, it's interesting. Methadone is a interesting beast to try to beat. Okay, so now we'll continue. So for monitoring these patients, the thing to realize is that the elimination half-life is greater than the analgesic half-life, which essentially means that it's going to take time to really start seeing effects in a lot of these patients. Now, as I said, this is a 4 to 8 hour duration of action. However, with that half-life being so variable, it can be up to a week before we actually see a steady state. It can be longer than that in those extreme cases. However, you have to realize that the adverse effects aren't going to necessarily happen right away. It's going to happen after time, after that steady state builds up to a level where they're at steady state. So just because they're on it for 3 days and don't have any shortness of breath or neurologic impairment, that could happen in a few more days, maintaining at the same dose. And that's why they recommend typically you don't make changes greater than every 7 days for more than 5 milligrams at a time, depending on what dose they're on. So if they're already on 50 milligrams of methadone daily, you might be able to increase more than 5 milligrams every 7 days, but it's going to be really specific with patients. So as I said, one of the things we worry about is QTC prolongation. And how are we going to determine if they have QTC prolongation? Unfortunately, it's not like something that we can necessarily listen to their heart with a stethoscope and determine. We're going to need an echocardiogram or an ECG to determine that. And figuring out who is most important to get these or who is most applicable is going to be important for us as pharmacists and as people that are trying to not only be safe for patients, but be cost safe or cost effective for patients as well. So the 2014 American Pain Society guidelines essentially says that if the QTC at any time in the patient's life has ever exceeded 450, if they have risk factors for QTC prolongation, such as an arrhythmia or on another agent that prolongs QTCs, which I have some listed over here, or if they have a history of a ventricular arrhythmia, we needed a baseline ECG before we start methadone therapy. Now, if they don't have any of those risk factors and their QTC has never been 450, it's going to be considered. It's going to be kind of determinate on what your clinical opinion is and what you think they need. So as far as the QTC prolonging agents, this is a not all-inclusive list, but this is a good portion of them. So antiarrhythmics can definitely cause QTC prolongation. Antipsychotics can cause it. SSRIs, especially we think about citalopram, causing it, but that is not the only one. Escitalopram can cause QTC prolongation, and pretty much any SSRI can cause QTC prolongation. TCAs can also cause it. Zofran, so ondansetron, which is problematic because, especially in the palliative care world, a lot of patients are going to have Zofran on to kind of prevent nausea. So it's going to be important to realize if they are on Zofran, you are going to be anticipating to start methadone in a patient. That would be important. And antibiotics, fluoroquinolones, metronidazole, and then fluconazole, Bactrim. Those four are some ones that can definitely cause QTC prolongation. Some other ones I don't have listed are tizanidine and famotidine. These have been shown in some patients to cause QTC prolongation. So really, what does QTC prolongation cause? It can cause torsades de pointe, which is essentially a ventricular arrhythmia, which can lead to cardiac arrest or sudden cardiac death. So it's a huge problem. It's not like an atrial arrhythmia, which isn't as death imminent, but this ventricular arrhythmia can be very problematic. So after we get that baseline, do we need another ECG? So if they have risk factors for QTC prolongation, if they have an ECG greater than 450 or history of syncope, you would want an ECG in 2 to 4 weeks after initiation of therapy. Also, you really want to look at it if they're at 30 to 40 milligrams a day, or if they get up to that point, it's going to be important to get another one, and then again at 100 milligrams. Past that point, it's going to be more clinical decision. But if the QTC ever does reach 500, you want to decrease or discontinue the therapy and transition to a different opioid. If it's between 450 and 500, you just want to be really cautious, because typically the greatest risk is when QTC is greater than 500 to go into that condition which I talked about, torsades. So drug interactions. There's a lot of drug interactions with this medication. One I want to bring up is Clopidogrel. So it has to do with liver enzymes, which we'll talk about in a little bit. But methadone actually decreases Clopidogrel clearance, increasing the AUC. So the problem with that is the decrease in clearance in the co-administration with methadone can decrease the Clopidogrel conversion to its active metabolite, and it may decrease its efficacy. So patients that are on Clopidogrel for whatever reason, whether they just had a stent and they're on methadone, what could happen is they could not be getting the efficacious dose they need of Clopidogrel, which could lead to either restenting or clotting, which we obviously don't want. Some antibiotics can cause problems, especially with increased levels. Typically, the antibiotics we think about with drug interactions to methadone are some fluoroquinolones like ciprofloxacin, macrolides, and the azole antifungals like fluconazole. Seroquel can also increase levels, so that's going to be important to realize, since a lot of times in palliative care, they're not only going to have requirements for pain, but they might have requirements for treatment of dementia, which Seroquel has been used for. Benzodiazepines are also a very commonly occurring medication in the palliative care world. So if patients are on benzodiazepines, it actually does increase the drug levels of methadone. Not only that, but it also increases the respiratory depression and mental impairment. So it's really 3 different stages or 3 different levels to look at with benzos and methadone use. So it'd be really cautious in using them. And then SSRIs can also increase blood levels. As far as medications that could decrease methadone levels, HIV medications typically decrease. There is one that actually increases it, but for the most part, HIV medications do decrease levels. And anticonvulsants like carbamazepine or phenytoin. Carbamazepine can sometimes be used as a coanalgesic for pain, but it's important to realize that these can decrease the methadone levels, so it might be important to, they might require greater doses to achieve efficacy. So side effects, the fun side effects. So obviously the typical side effects of opioids, we're going to have sedation, respiratory depression, nausea, you can get pruritus, constipation. The one thing I talked about a little bit is the QTC interval increase, and that's due to the human ether agogo related gene in the cardiac channel. It affects that, which causes that QTC prolongation or QTC increase. And then another thing that I noted is that it actually does cause an increase in weight. Now, there was a study done essentially looking at patients over a 6-month period, and they found that there was a 17.8 pound increase or 10% increase in overall body weight in patients that were given this. The biggest predictor of that was gender. So females increased by much more than males as far as weight. They had a 28 pound increase, which was 17.5% increase in body weight, versus a 12-pound increase or 6.4% increase in males. Another thing to realize is that these side effects are not, they're dose dependent, but you can't measure blood levels to figure out what's going to happen. There have been toxic blood levels of methadone ranging anywhere from 60 milligrams per mil up to 450 milligrams per mil. Now, methadone is not something that we typically test for blood levels for, but it is important to realize that since genetics do play a relatively big role in this medication, that it's going to be something to consider as far as side effects go. So methadone is a coanalgesic for palliative care and cancer pain patients. So there was a study released in 2016 of July from Quebec, which essentially looked at patients that were on opioids, typically hydromorphone and fentanyl. And they looked as methadone, adding that onto those therapies to see if patients had increased pain or decreased pain rather. So 49% of patients significantly responded to low-dose methadone, which was essentially a greater than 30% reduction in pain intensity. Now, the time to effect was 7 days, which is pretty typical because we want them to get to steady state before we actually determine that. And then you can see the mean initial methadone doses was 3.5 plus or minus 1.5. So anywhere from 1 milligram to 5 milligrams per day was the initial dose in these patients. You can see the oral morphine equivalents, so the mean and the median. They were on decent doses of opioids, so I wouldn't say this would be a great choice in patients that are on low doses of opioids. However, when looking at this, it's important to realize that this can have good effects, and half the patients in this study actually got a 30% pain reduction just from a low-dose methadone, which not only is it a cheap medication, but at these low doses, side effects, you don't have to worry about as much. Now, obviously, you're always going to have to worry about QTC prolongation and then sedation, respiratory depression. However, at these low doses, it's not as big of a problem. So essentially what they say is that we should assess the response after 7 days in these patients. In this study in particular, there was a plateau that was seen. So most patients in this study did not improve after the initial dose. Even if they went up to higher doses, it was either they're going to improve at these low doses when they're on other opioids, or they're not. There's not a whole lot of reason to go up in methadone. So it's more of a trial. So if you try it for a week and the patients have a good response, then you can keep it on, and that it's beneficial for the patients. However, if you try the medication and there's no response, it might be important just to kind of take it off to prevent going higher doses expecting to get a good response when you're really not going to end up getting a good response, at least according to this study. Another thing that's important with methadone is the pharmacogenetics. So it used to be believed that CYP3A4 was the most important factor, and that was due to rat studies that looked at methadone use, and it seen that when you inhibited 3A4 that it was a big factor. However, research has come out that found that CYP2B6 is actually the primary determinant of clinical methadone elimination. It is a highly polymorphic enzyme, so there's a high rate of variability, especially in whites. So in African Americans, there is 33 to 50%. So the metabolism and clearance of methadone was about 33 to 50% lower because of different alleles. So whites have about a 14 to 30% chance of having an allele that would be different outside of the norm, and then Asians have about 10 to 20%. So CYP2B6*4 is actually found to cause an increased clearance of methadone, while CYP2B6*6 found to have a decreased clearance of this thing. And it's more influential on S isomer than R, so it could be more problematic in determining QTC, since the S is a little bit more important in the QTC prolongation. Some other pharmacogenetics or genomics that were looked at were CYP2C1 or 2C19, which is essentially well, I guess let me talk back about 2B6 a little bit more. So some things to think about with 2B6 are other medications that can either bind to those receptors, or not receptors, but can be degraded by those enzymes or can inhibit those enzymes. So bupropion, sertraline, and efavirenz are all 2B6 substrates. So Wellbutrin is something that we'd want to look out for when starting methadone therapy, because it could be a good interaction, as well as sertraline, which is something that I found somewhat unique. Some actual inhibitors of 2B6 are Clopidogrel, Clopidine. They're both weak inhibitors. However, it is important to realize that if you are inhibiting that, you are increasing that risk for side effects. So CYP2C19, they essentially found that with methadone dose, the breakdown product of methadone, the EDDP, and then the concentration of those was associated with QTC. So essentially, when you have a problem with your CYP2C19 enzyme, you could also have problems with QTC as well, the 2B6. Some other enzymes that are associated with methadone pharmacogenetics are CYP2D6 and CYP1A2. And that's it. So now we'll open it up to any questions that I might answer. And this is a free-flowing topic, so if there's anything that I misspoke about or anything you'd like to add, please do. I will not get my feelings hurt about this.
Are you all able to unmute yourselves? I just want to make sure that I have this set correctly. Okay, everybody is unmuted now. I can unmute and mute myself. All right. So, Brad, are you guys using methadone in your hospice program?
Yes, we are using methadone in our hospice program.
Are you all doing conversions, or are you kind of following the Lynn McPherson teachings of, you know, like really low dose as an adjunct almost?
So we use conversions. Now the problem is what I started doing is doing the 75 to 90% decrease, but I don't go off that entirely because these patients are a lot of times in a lot of pain, and it's not good to get calls from these patients screaming in pain. You're trying to decrease the pain and make their palliation. I mean, we're palliating them. We're trying to, make them comfortable. And when you're starting at super low doses, because a 75 to 90% decrease is significant, it's really not good for the patients. I mean, especially at end-of-life care where we're trying to just make them comfortable. So yeah, we typically do oral morphine equivalents, and then we'll decrease the dose.
Okay.
And as far as the HIV drug clearance, that is Dell.
Which HIV drug clearance is decreased by methadone?
So Delviridine is the only that one increases the blood levels. Pretty much any other HIV medication will decrease the blood levels of methadone. So Delviridine is the one that will increase the levels. All the other ones will decrease it. So Lee, I guess the real question is, so is it for chronic pain? Is it something that they're coming in on opioids and something else, or is it like post-surgery, or what's the indication?
We've had a few patients that have had really high oral morphine equivalents and also neuropathic pain that we thought that methadone, they'd be great candidates for it. But whenever we speak to the attending, they are really hesitant to really, I mean, in our hospital, we are allowed to put in our own orders. They're really hesitant to let us manage that and start it. And they say, well, we don't want them to be here for a week or two while we're waiting for that to get to steady state, and we're worried about QT prolongation. And we really just don't use it a whole lot because a lot of our physicians are afraid of it, or they're just not really educated. And I've held a couple in services, but mostly to the resident level. I didn't know if you had any thoughts or opinions about that.
I mean, obviously education, like you said, you got in services is going to be really important. And I mean, there is a true fear out there because, I mean, methadone deaths are very common. So it is a scary thing. Now, what you're saying with neuropathic pain or high dose opioids, it seems like the perfect candidate for methadone. I mean, the only thing you can really do is, what you're supposed to do anyways, is start low and go slow. And really education, they're going to be scared. Physicians are going to be scared of methadone, I think, no matter what we do. So I really don't know a good way to help guide them, unfortunately, other than educating them, saying that, it does really have good effects, especially for like neuropathic pain with other pain, chronic nature.
Thanks.
How do you all feel, or Brad, how do you feel about concurrent methadone and benzodiazepine use in the hospice population? It's something I haven't quite figured out how I feel about.
Well, I think, I'm not going to say it's okay. I think you have to be really, really cautious, because benzodiazepines in hospice do have their place. I mean, a lot of these patients are in severe anxiety, and it really does affect their quality of life. However, with methadone, since it does increase methadone levels, since it does increase respiratory depression, since it does increase CNS depression, it's going to be something that you're really going to have to watch. And if you're going to start methadone, if they're already on a benzo, I would say likely decrease the dose of that benzo. Likewise, if they're on methadone and they're really anxious, I mean, start at a baby dose of a benzo. I would be very, very cautious about using the two together.
Okay.
And I'm not sure if there's any studies out there looking at the two. I haven't found any, but that would be something interesting to see if it was out there somewhere, methadone use with benzodiazepine in hospice patients.
So Lisa, pharmacogenomic, if we had pharmacogenomic data on patients.
I definitely think it'd be beneficial. Now, obviously, we're still learning new things about methadone as we are with pharmacogenomics in general, but I think it really does have a place, especially if you're anticipating that they're going to be on long-term doses and kind of determining how high of a risk they are for having some of these side effects, depending on what their alleles are with 2B6 or some of the other ones I mentioned, like 2C19.
Now, does anybody know if other labs are offering the 2B as in boy 6 genotyping other than Millennium? I know Millennium was the only one for a while there that offered it. I don't know if others are or not now. We actually had the contract set up to do that out at the base because we were using a lot of methadone out there. But I haven't had a lot of new start methadones at higher doses that would necessitate it. Nobody? Quiet group today, huh, Brett?
Yep, that's okay. It's Friday. They're just probably thinking about the weekend and enjoying the sun. We're going to have sun.
Oh, heck yeah. Let me ask this. What do other people think they might like to hear about in the future? I see the methadone at a hospital is an issue. There's a lot of people out there too, Leah, that question the actual risk of methadone in QT prolongation based on the studies that have been done, and are we tagging all of the issues that we're seeing with methadone and missing the boat on other potential concurrent therapies that could be contributing?
Yeah, I think you're exactly right, Chris. From what I read, like 90 to 95% of the methadone-related deaths had other factors for QTC prolongation outside of methadone. It wasn't just methadone.
Is anybody else doing routine EKG monitoring in their patients that take methadone for pain? I know we do at our clinic. All right.
Okay, guys. Well, if there's no other questions, I appreciate you for listening to me for a while.
I learned a bunch. Are we after you're looking into all of this, do you feel we're doing it correctly, Brad?
I think so. I mean, I enjoyed putting the presentations together. I learned a lot making the presentations. And like Chris said, if there's anything you guys want me to talk about next week, that'd be awesome if you'd let me know, because otherwise I'm just going to pick something and have that topic. But if there's something that you guys want me to talk about, I can definitely choose that.
Is anybody on the webinar right now a current PGY-2 in pain and palliative care? Do we have any PGY-2s in pain and palliative care on the webinar? If you have any interest in presenting one of these, please shoot me an email with when you might like to do it and the topic, and we'll get you on the books, okay? All right, Dr. Rea, great job as always. I learned a bunch. I think that it's a highly underutilized medication, especially in our hospice patients.
I agree.
And hopefully we can keep working on Dr. Middendorf to increase our use of that particular medication.
I actually recommended it as a Coanalgesic yesterday in a patient that was on high-dose opioids uncontrolled.
Did they take your recommendation?
Yep, 2.5 twice daily.
Boom. Drop the mic. All right. Thanks, everybody. Have a great weekend. Hopefully it's sunny and warm where you live, and we'll see you next week.
Thank you, guys.